think it's better we start with Mulligan because Mulligan is the easiest one of all of them. All right. So we're going to look at Mulligan, and or should we just look at the general technique? Where's my general technique? I think I've discussed part of that one. We're going to look at Mulligan for cervical. Then we now look at serious. All right. This is a bit much more complicated than Mulligan. So let's go Mulligan now. We're going to go Mulligan now. Let me take this one off. All right. Okay. Right. This is Mulligan technique, colleagues. Now, let's have a little introduction to the techniques. It's not going to be a voluminous book of Mulligan. I have extracted the most important information that we can easily pass across so that we can go from here and begin to apply this technique as it works. All of them works. It's just knowing which one to use for which point at a particular point in time. Brian Mulligan described a novel concept of what's the brain behind Mulligan. The brain behind Mulligan is that glide the joint. You know that gliding, as pushing on the joint to support the joint. The brain behind Mulligan is to push on the joint to support the joint. And after you support the joint, you now ask the patient to do the movement they find painful to do before. You know those things like when we are young and you hit your head against the wall and you cry to your mommy. And mommy says, oh, sorry, my dear. And mommy rub hand on that part of your body. The same thing is that's the way I see Mulligan. A patient is having pain in the neck and is not able to do flexion and extension. Therapists come and apply glide to stabilize the joint. And you now ask the patient to repeat the movement that was painful earlier on while you maintain the glide. That's the basic summary of Mulligan technique. And one of the important tenets of Mulligan is that while you are applying that glide and patient is carrying out the movement, there must be no pain. If you are applying the glide and patient is carrying out the movement and there is pain, you will drop that technique and try something else. All right? There must be no pain. And even after you have finished your treatment, patient must be able to experience pain reduction. If you don't have all these conditions met, please use another technique. Okay? That's just a brief introduction into Mulligan. What are the techniques of Mulligan that are available for the cervical spine? You know, Brian Mulligan's concepts include natural apophysic glide, sustained natural apophysic glide, movement with mobilization. All right. We're going to look at each one of this one briefly before I show you one or two videos, and I'll refer you to my YouTube channel where you can watch the rest of the video because of our time. All right. I'll not be able to project all the video here. So I'll just show you one or two. Then I'll give you the YouTube channel where you'll be able to watch the rest of the video. Okay. Now, so we have natural apophysic glide, NACs. We have sustained natural apophysic glide, SNACs, and then we have movement with mobilization. All right. Now, for the SNACs, let's talk about the SNAC first. I will just explain. At your leisure time, you just go and read the notes so that I'll be able to meet with time. Now, this patient supposedly that you are seeing on this slide is having problem with flexion and extension. So I want to apply Mulligan technique. After my assessment, subjective, objective, and all the assessment we used to do, I will now put my thumb below the spinous process where the pain is being felt. Like this patient is feeling pain at C6. So my right thumb is below the spinous process of C6 and the left thumb is supporting it. Do you understand? You can see the two index fingers were pointing away so that I will not accidentally put the finger on his jugular vein or his trachea. That's why the two index fingers are pointing away. You will also notice the direction of the push. The direction of the glide should be towards the eyes of the patient. That's what Mulligan teach. It should not be directly perpendicular to the occiput. It should be inclined upward as if you are pushing towards the eye of the patient. That's all you have to do. Maintain that glide. Ask the patient, I hope the glide I'm pushing, I hope the movement I'm applying is not giving you pain. If your glide is painful, reduce it. Otherwise, maintain a very firm guard and ask the patient to now repeat flexion and extension. As the patient is doing flexion, you are moving with the patient because you have to maintain that glide. As the patient is coming back to extension, you are moving back with the patient, you are maintaining that glide. Do you understand? So the patient can do 10 movements of flexion and extension. If that is the only problem, after 10 movements of flexion and extension, you reassess. If the patient make progress, repeat it 3 to 5 times. If there's problem with side flexion and rotation, the same procedure. Apply your glide, ask the patient to now do the rotation, and you move around with the patient as he's doing the rotation, because you have to maintain that glide intact. And the same thing with side flexion. That is what is called SNACS, sustained natural apophyseal glide of Mulligan. I ought to have teach NACS before SNACS. I hope I've not jumped slide though, because NACS ought to be taught before SNACS. Oh my God. Oh, there is a problem. I think, okay, NACS is here anyway, so we're going to see it anyway at the end of the day. So this is SNACS, guys. Apply glide with one thumb. You know, we said you can deal with cervical with thumb. It's only the lumbar you deal with pisiform. Apply glide or slide below the spinal process where the pain is felt with one thumb. Reinforce it with the other. Ask the patient to carry out those movements. Your glide must not be painful. The patient must experience pain relief while he's doing that. Don't underrate this technique. I lost my collection just some few moments ago, so I have to start again. I'm sorry about that. I'll just reconnect. I don't know what's responding is network. All right, so this is where we were before we went off. We're discussing NACS. So that is NACS. Then I'm going to show you a video of the NACS anyway, so you understand better. Now, after you've done like that 10 repetitions, 3 sets in the clinic, you can also teach your patient to do it at home with a towel. And that is what is called the self-SNACS. So instead of your hand or your thumb, they will now have to put a towel, apply with slight tension below the spinal process where they are feeling the pain. After applying the towel in that order, they will now carry the movement that otherwise has been giving them pain. 10 movements 3 times. You can see the diagram above on the left-hand side. The diagram above on the left-hand side, she's trying to do extension with SNACS. So there's a bit of glide with the material she's using below the spinal sphere of the pain. The one on the right is doing rotation to the left. You can see that the hand holding the towel on the side of the rotation is down. The towel is also down. So the hand on the opposite, the hand holding the towel on the opposite side is the one that is applying the tension so that the direction for movement can be created. So this is self-SNACS, okay? Very easy treatment technique. And that's why I say I think we should discuss Mulligan first. And Mulligan is not a technique that is meant for patients that have a very bad pain for many years. If the pain is very recent and is very acute, NACS and SNACS are the techniques you want to start with. All right? So this is SNAC, sustained natural apophyseal glide. It's called sustained because you have to apply your finger and follow the patient throughout the movement. That's why it is sustained SNACS. And then we have the NACS, which is natural apophyseal glide. NACS is natural apophyseal glide. So, in natural apophyseal glide, what happened? I'm going to explain to you. This is usually the first one you do when the patient pain is like 8/10. and he doesn't want anybody to touch him or her. And what you do basically, let me share the slide below. That would be better. Okay, this one is better to start the explanation on natural apophyseal glide. The first thing you do again, look at the diagram above. You will identify the spinous process at the level of the pain. And you place the little finger, all right, the little finger of the stabilizing hand. Decide which stabilizing hand you want to use, whether your right or your left. You place the little finger of the stabilizing hand below that spinous process, just as you have it in this diagram. That's why I bring that diagram up. After you have done that, you will now use the thinner eminence. You will cover the little finger with the thinner eminence of the opposite hand. Can you see that in the middle? And by the time you have done that, you will now push from mid-range to inner range. This snag movement is from mid-range to inner range, mid-range to inner. So it's a very small amount of movement that works when the pain is on the eye side. So the oscillation you are going to be delivering will be from mid-range to end range, mid-range to end range, mid-range to end range. And you do 10 of that, you reassess. Patient has improved, you can deliver up to 30 or 50 of that, 3 to 5 sets. The diagram you are looking at the bottom is what is called unilateral nags. You know, the upper one is called the central nags because it's delivered below the spinous process. This one is called unilateral nags because it is delivered on the facet joint. You remember we said yesterday during the anatomy that spondylosis chiefly occur in the facet joint. It can also occur in the symphysis joint, but it chiefly occur in the facet joint. So if you want to go to that facet joint as area of pain, you can also deliver nags and snags, in which case it will be called you take a thumb distance away from the spinous process and you go slightly below. You will find yourself on the facet joint. So when it is done on facet joint, it's called unilateral nag or unilateral snag. Okay, I hope you are still able to hear me because of this different connectivity problem. So this is nags and snags. I hope I'm still connected.
Yes. Your slide. You can't see your slide.
Okay.
I can't see.
Oh, all right. Okay, I get it. Is this different? Is this multiple internet connectivity problem? So that is nags and snags. I'll show you the video in a short while, and you have ample time to watch on my YouTube. You see them also. But it is facet joints when you move your arm, when you move your glide laterally, one thumb laterally and slightly below the spinous process, you will land on the facet joints, okay? And then that will be unilateral nags. So if a patient comes with spinal spondylosis of the cervical spine or even radiculopathy and the pain is so much and the pain is across the neck, you can do the central nags. You can start with nags if the pain is on the eye side. Do the central nags, do the unilateral nags. After the pain has come down, then you move to snags. That's when you apply the glide and you now ask the patient to move the neck. Okay, and you follow the patient through. All right. Then after snag is okay, it has been able to relieve the pain, you can now move to the next one, which is mobilization with movement. This one is called mobilization with movement. How is mobilization with movement different from snacks? Again, you will apply your glide below the spinal process where the pain is being felt with one hand or with the thumb, and you will use, the therapist will use the rest of the finger to move the head of the patient for the patient. So it's the therapist that is moving the head now into flexion. You can see from the upper diagram, my thumbs are below the spinal process of the pain, and the rest of my finger is holding the mandible in order to produce movement of flexion and extension and rotation. So I'm the one carrying out the movement. It's the therapist that is carrying out the movement. Or otherwisely, you can use one thumb to provide the glide and use the fingers of the other hand to carry out the movement. So you carry out flexion, extension movement 10 times, rotation 10 times, side flexion 10 times, you reassess, is better, you repeat 3 times. That's why I said Mulligan is bread and butter for anybody who wants to practice it, especially when the pain is a bit on the high side. So I am going to stop this one here. This is the Mulligan technique for cervical spine, and show you one video clip of Mulligan before we go on to the series. But if you go to my YouTube, you see all the video clips for Mulligans. They are all there. So let me just pause here. I'm going to stop sharing, and I'll connect with the video of one of them so that you can see for the next 1 or 2 minutes. Please stay where you are. I've not gone away. I just want to show a video clip, and later you can go to the YouTube and look for all of them. Okay, Mulligan with mobilization. Which one should I even show? Maybe we should show 1 or 2. This is Nax. This is Nax. Let's do this Nax first. Oh no, oh no. Is it gonna work? Okay, let me see. All right. I'm coming, oh, I'm coming, guys. I just want to get it on. All right, let me come here and share screen. Can I see it? Yes, it's there. Can you see the description there? That's from my YouTube. That is Nax. All right. So the little finger is below the spinal process where the pain is felt. Thinner eminence of the other finger is covering the little finger. Then you push from mid-range to inner range. Can you see the movement, guys? Like 10 times, and then you reassess. It's a very small amount of movement, especially when the pain is high. When the pain is relieved, you repeat it 3 to 5 times. That is NAX, Natural Apophyseal Glide. Like this one is done below the spinal process, it is central NAX. If you deliver it on the facet joint, that is, if you move one thumb breadth away from the center and slightly below the level of spinal process, you'll be on the facet joint. So you will be doing unilateral NAX. Okay. Let us quickly look at snacks. I think we should look at now or movement with mobilization. Any one of them, then you can watch the remaining one on my YouTube at your convenient time. Please don't go away. Okay, this is movement with mobilization. You can see that one thumb of one hand is providing the glide, and the other hand of the therapist is the one doing the flexion and extension. All right, is the one doing the flexion and the extension. Let me play it again. See another version here, whereby the 2 thumbs are providing the gliding, and the other hand of the therapist is the one providing any movement that the patient so desired. You do 10 of that, you reassess, and then you progress. Okay, I'm going to stop sharing so that we move on. All right, thank you very much. That is Mulligan for cervical spine. Already you know the anterior, posterior, anterior. You know, those one I've shown you with the vertebrae. Those are techniques that we can do as well. And you will find all of them on my YouTube channel. Time will not permit us to go through all of them one by one. I have to move to another technique now for the cervical spine, which is the serious technique. Like we promised, the serious technique. That is where I will be moving to now. Just give me a second to connect with my PowerPoint. Very serious, okay. Serious is here. Okay, guys, I projected the serious on your screen. Now, let me say this before we go into serious to make it very easy for you to understand. Now, you know, if a patient is having discopathy or radiculopathy, let's say disc herniation, or something is blocking the movement, that's when serious is good. General pains, spondylosis, or radiculopathy, you can use Mulligan. But if a patient is having movement restriction in one direction, I'm sure we have seen them before. They will bend their neck to one side. They will bend their neck away from the side of the pain. They will come to the clinic for physio. This is when you can use serious. All right. Serious identify that any patient with cervical problem like this, they have areas of movement restriction. That is where the pain is. And they have area of least restriction. That is where there's no pain. Do you understand? So what serious advocates is to take the movement, about 3 or 4 different types of movement, one stage after the other. So if a patient comes to your clinic with neck bent to the left because there is pain on the right, if you want to use serious technique, you are going to lie the patient down and carry out
Please, sir, it's as if the slide is not moving, sir.
Oh,
sorry,
all
sir.
right. You cannot see my slide?
It's not moving. Yeah, now I think it's moving now. It's just showing
okay, you can see the slide now.
It's just the first slide. Yes, sir. Thank you, sir.
You can see the first slide now. Can you?
Yes, sir. The cover slide. Yes, sir.
All right. Okay. All right. Let me just go to this one. I hope you can see this one. Let me just start my explanation here.
Okay, sir. Thank you.
Are we together? Can you see my slide?
Yes, sir. Very well, sir. Thank you.
Yeah, we can see.
All right. Now, this is what I'm saying. Serious technique for the cervical is good when you have discopathy, radiculopathy, slip disc, all those things that make movement difficult in one position. So serious identify areas of movement restriction, and they identify area of comfortable direction. You understand that? So if a patient is having pain on the right, we call that area of movement restriction. The left side where there's no pain or little pain is area of comfortable direction, according to serious. So what serious advocates is that if you have a case like that, lie the patient down. The first movement you should do is to try and restore that neck that is bent to one side to the neutral position. So the first technique you will apply is the straight pull technique, straight pull traction. That's why you have straight pull as number 1 on this slide. After you have applied the straight pull, you achieved it, and the patient is okay with it, you will now go to the second technique. The second movement you carry out according to serious is you will now do rotation in the painless direction, in the comfortable direction. Don't forget that the right is the painful direction, the left is the comfortable direction. You will do rotation in the comfortable direction. You now be asking me, why should we move in a comfortable direction? It is required because as you are doing that traction with rotation, you are opening up the joints so that whatever it is that is blocking the joint can get resolved back to its comfortable position. Okay? So you do rotation with traction in the less painful direction. Once you have achieved that to full range, you might be able to achieve that into full range on the same day, or that might be where you will stop that day. The patient will come the following day, you move to step number 3. Step number 3 is that you will now try lateral flexion on the most comfortable position. We are still not touching the area of pain, no, that right side that the patient did not want to move. You leave them till the end. You will do traction with lateral flexion on the most comfortable direction. Once you are able to achieve full range with that one again, that is when you will now start concentrating on the painful direction. The benefit of this traction with rotation, traction with lateral flexion on the painless side is that you are going to create a gap, you are going to create a tension, which is necessary to resolve whatever it is that is blocking the joint. So that's the first 4 maneuver you are going to do. Once you have achieved that, Sirius now said you will now lie the patient down and you will now rotate in the direction of the pain without traction. You will not apply traction. You will just simply rotate. All this rotation in comfortable position, lateral in most, all these 1 to 4, they are with thrust. They are manipulation. You are going to apply high velocity, low amplitude thrust. If you don't want to apply thrust, you can do mobilization. All right. So once you have achieved full range in the good direction, you will now rotate in the opposite direction where there is pain. You achieve full range, you go to lateral flexion or side flexion on the painful side. Once you have achieved full range, you will now smoothen everything up. Like you are plastering a house and you have already plastered it. You now sprinkle some cement to now make it to shine and look beautiful. You will smoothen everything up with anterior-posterior glide and lateral glide. So if you look on your slide, you see a list of about 7 techniques. So for cervical spine discogenic pain, you apply straight pull first, then you go to rotation in the most comfortable position, lateral flexion in the most comfortable position, then you go to rotation in the least comfortable position, lateral flexion in the least comfortable position, do anterior-posterior glide, and then you do lateral glide. I'm going to show you the slide one after the other before we now show the video. Before we now show the video for that, okay? So let's just go. If you look at this, this is the straight pull description. You know, straight pull is the first thing that Sirius described. That patient that the neck is bent to one side, get him to lie in supine. You can get assistant to hold on to the shoulder so that when you apply your pull, the patient is not coming with you. So what would you do? One hand on the occiput, one hand under the chin. Be careful not to compress the trachea of the patient. Anchor your leg on the crossbar, on the plinth, and lean backward. It's your body you are going to lean backward. As you lean backward, the patient will feel the tension. He will feel the traction. As he's feeling the traction, his pain should be less. And you need to keep talking to the patient to give you signs. Is your pain getting less now? Give me a sign. If you give you a sign, so you know where to stop pulling. Is that okay? So you hold it like that for a few seconds, 10 seconds. You relieved it. Patient feel better. Repeat it 3 times. So you have already finished the first stage of Sirius approach to cervical discogenic pain. The main purpose of this stage is to relieve pain. Kawaii. You just want to do this one to relieve pain before you now concentrate on regaining the range of motion. So the straight pull is the first thing. After you have done the straight pull, you move to the next technique, which is what? Rotation in the most comfortable position, followed by lateral flexion in the most comfortable position. How do we achieve that? This is what you are seeing here. You are going to read it when you get home. Again, to do this rotation, you will decide which side you want to rotate. Do you understand? And you know, according to Sirius, he said we should rotate first in the least painful direction. Least painful, most comfortable. So you will still apply the straight pull like we do before, just like you apply manual traction to cervical spine. Some of us that have been doing manual traction cervical spine, you understand what I mean? Just like you apply manual traction to the cervical spine, you will maintain that traction, sir. You will maintain that traction and then rotate the head of the patient in the painless direction. You know, the patient will not oppose to you because you are not going in the painful direction. You go in the painless direction until there's no more movement. When you feel there's no more movement, you can then begin to oscillate. Just begin to oscillate 5 to 10 times. Then you repeat and you repeat. If you do that, you are doing mobilization. But if you apply the traction and you move in the direction of rotation until there's no more movement, and you ask the patient to breathe in and breathe out, And at the sign of breathing out, you now apply high velocity, low amplitude movement. You can even hear a pop sound. What you have done is manipulation. So you are free to use either mobilization or manipulation. You reassess. If there's improvement, you will repeat 3 times. I'm going to show you a video clip of this one. All right, so that we'll see exactly what we are talking about. But it is first straight pull, followed by rotation in the most comfortable position, and followed by lateral flexion in the most comfortable position. Let's have a look. This is illustrating the lateral flexion in the most comfortable position. Again, you apply the straight pull, and then you swivel your leg. The therapist, you will see it in the video. You have to swivel your leg to the side you want to do lateral flexion to, which is the direction of less pain. As you swivel your leg in that direction, even the neck of the patient will come automatically into lateral flexion. Then you will now turn it until there's no more movement. If you want to mobilize, just oscillate and repeat the whole procedure. If you want to manipulate, once you get it into that end range, when there's no more movement, ask the patient to breathe in and out, breathe in and out. When the patient is breathing out, you will deliver high velocity, low amplitude movement. We'll show this one as well. So once you have done that and you have achieved full range of rotation and lateral flexion in the most comfortable position, you will now go to the painful direction, in the most restricted direction. You will just simply turn the neck. You are not going to do any thrust here. In the painful direction, you simply turn the neck in rotation. As you are turning, if the patient said, "Oh, I feel pain," you will stop and wait for the pain to subside. When the pain subsides, you will continue to turn until you achieve full range. Once you achieve full range with rotation, you will treat lateral flexion the same way, no traction. So once you have achieved rotation and lateral flexion in this direction, that is when you will now perform gliding. The one I said is like a cement to smoothen everything. You will perform anterior-posterior glide and you will perform lateral glide, which I'm going to show you in the video. So please don't go anywhere, just stay where you are. But before I show the video, please listen to this one. It's very important. This is lateral gliding. We are going to show it in a short while. So you can go home, read the slide and watch the video, and you can marry the two together. Now, before we go on this one, if a patient, sir, listen to me, sir, if a patient is having posterocentral disc herniation, like I discussed with you yesterday, and it is massive, how would you know? Pain will be going to both upper limb. Please, and please, and please, use only straight pull. Don't use rotational maneuver. Don't use lateral flexion maneuver. You can only use straight pull, because if you use rotational maneuver, the pain can aggravate. Just do your straight pull, or you do simple cervical traction for them. That is if there's posterocentral and pain is radiating to both upper limb. I hope we understand. Now, these are the websites, or these are the URL link for those videos that you are going to watch on your own computer. But I'm going to show you some few of them now so that you see exactly what we are talking about before we'll go to the lumbar spine. So please stay where you are. Let me open up those videos. Oh no, this is another one. Please just stay where you are. I will connect with you now. All right, I will need to explain this slide. This is not the serial, so this is the one I got. This is the one I told you about, transverse oscillatory glide. If you want to gain rotation, that you have to push on the side of the spinous process. Just a second. I'm going to go to the serious now. That is gaining rotation by pushing on the facet joints. You know, that's one of the things I said for rotation in the earlier slide that we have. And you are going to see the transverse oscillatory glide now. Oscillatory glide on the side of the pain. You push to the side of the spinous process. See,
Sorry,
we're
sir.
pushing.
The video is kind of breaking. It's not like smooth. The transition isn't smooth.
It is network, madam. I'm sure you will see it better when you watch it on your own. It is network. I'm sorry about that. Let me go and show the series. Hopefully, we'll have a better view with series. The links are there. You can watch them on your own, and you'll see exactly what I'm talking about. Let me try and get the series technique on. You know why that is not here, but it is here. All right, I have series technique. I want to show the rotation first. Series cervical technique, series cervical. Where are the video? Oh my God, the video are not here, but I'll find it because I have it. Just a minute. Beg your pardon. Series glide, series segmental rotation. Okay, let's have a look at this one. Let's have a look at this one. Just one or two of the series. Okay. This is serious. You know, we said you do rotation to the painless direction, lateral flexion to the painless direction before you now do it to the painful direction. This is illustrating the rotation. But all of them are on my YouTube. The straight pull, the rotation, the lateral flexion, they are all there. They are all there. I hope the video is better this time around. It's not breaking. And if it's still breaking, I apologize. I'm sure you'll see it better when you are watching maybe tomorrow or something on your own. Maybe it's the network problem from my side. I'm still teaching here. That is it. That's the rotation. That's the rotation that has been done. That is manipulation. You can see it is high velocity, low amplitude. If you don't want to do manipulation, if you are not confident enough or you don't want to do it, you can just move it to the end of the range and keep oscillating. Keep oscillating. You just keep oscillating. You can see the oscillation there. No manipulation now. That is just oscillation. That is just oscillation. You can do that as well, and your patient will make a very good recovery. Remember, you go to the painless side first before you now go. That is the manipulation aspect that you can do as well. Never manipulate unless you have the neck on traction. If you have the neck on traction, you are pulling and you manipulate. It is absolutely safe. No problem at all. So that is that one. I'm going to stop sharing this. I want to show you a bit of the anterior posterior glide, the Baba Wunga's technique, something similar to Baba Wunga's technique. We've seen transverse oscillatory pressure, but we can also see like the posterior anterior thrust before we now move to the next segment. Please stay where you are, sir. Okay, where is serious? This is serious straight pull. This is serious posterior glide. Oh, no, those ones are not here. Those ones are not here. It's just a combination of serious. Let me show you another serious glide then. But I can get whatever I want. I don't know why this one is not coming out. Just give me a minute. Okay, let me see. I hope I've not lost you. Oh my God. Okay. Where is this thing? Anterior cervical, anterior posterior. This is serious. Serious. Anyways, in order not to waste time, let me just quickly show what I have. I'm sure you can get everything on my YouTube. I am very sure of that. Just go with the notes and open the YouTube and you'll be able to understand everything that we have talked about. Let me share this one. Okay. This is the glide you are going to do at the end. The one I said you do like cementing the neck. This is after you have achieved rotation and side flexion to both sides, you now do anterior posterior glide and lateral glide. The one that have just been demonstrated is anterior posterior glide. Is the anterior posterior glide towards the end of serious maneuver. So therapists still apply a pull. It's always important to apply a pull. Then it's going to push up with the lower hand and push down with the upper hand while he's slightly bending his knee. You can see the net movement at the cervical spine of the patient. So after you have achieved full rotation and full side flexion in both directions, that's when you do this AP glide and the lateral glide, okay? So I'm going to stop this one and then we'll move on to the lumbar segment. It's very painful. I want to really show the AP glide, posterior anterior glide. I'm still going to look for it. I'm not going to give up. I don't know where I kept it. But I can get it. Just give me a minute. I go to my video. I will get it. Let me just check. Because I still have time. I booked 1 hour for this and then 1 hour for the lumbar spine. Cervical video. Okay, they are here now. UPA, CPM, UPA. This is posterior anterior. All right, now I can use this one. Let's go. Now you're going to see, if you don't want to do serious, it's too complex, you just want to do a simple posterior anterior glide, you can do. Do at the center and do it on the facet joints. Can you see the fingers on C5 or C6 on one another? You see the manner in which the oscillation will be delivered now. Keep your elbow straight. That's graded oscillation. You are hoping to deliver 2 oscillations in 1 second. So if you continue like that for 1 minute, you would have delivered 120. Excuse me. If you deliver 120 oscillation on somebody's neck, the pain will change now. The movement will come. And don't forget what I said. If you want to gain flexion, apply this oscillation on the upper vertebrae in posterior anterior direction. If you want to gain extension, apply it by pushing the spinal process down. That will be anterior posterior direction. If you want to gain rotation, push on the side of the spinal process. That's transverse oscillatory pressure. And you push on the facet joints. You get all the illustration on those videos. All right, so we're going to move to the lumbar spine. We're going to move to the lumbar spine so that we can close within the time that we are allocated. All right, thank you very much for your time. But let us discuss the lumbar spine. So let me get out my PowerPoint on lumbar spine first. And then we go to the videos. So lumbar, and this is my PowerPoint. All right, and then I'm going to share that with us. Share screen, lumbar, that's lumbar. All right. Okay, so you have my screen for the lumbar spine. Let's move on to the lumbar spine as promised. So in this presentation, sir, we're also going to learn techniques that are suitable for lumbar spine. You know, at the start of the teaching, I said manual therapy or mobilization can be general technique or specific. I'll show you example of one general techniques, and then one or two examples of general techniques. Then we now go to specific techniques before we now look at serious and mulligan again for the lumbar spine. All right. Example of general techniques that we can use for the lumbar spine include a technique called PPIVM, passive physiological intervertebral movement, and then general rotation and extension. And you can see the specific technique include posterior anterior thrust, just like we did on the cervical, and then unilateral posterior anterior thrust on facet joint, just like we did on cervical. Once you have understanding of the cervical, the lumbar is not hard at all. Well, what I'm trying to teach on this slide is to emphasize to my students that the importance of knowing the landmark before they go to manipulate. Because if the MRI and X-ray said the problem is between L4 and L5, you have to go to either L4 or L5 to do your mobilization or manipulation. So what will happen to a therapist that doesn't know how to identify the landmark? So that's exactly what this slide is all about. And it's not hard. If you put your hand on the waist of the patient, that's on the iliac crest, and you draw the hand backward, you know you are going to land at the junction of L4 and L5, like we have in this diagram. If you put your hand, if the therapist puts his hand on the waist of the patient, on the iliac crest, and you align it back, you will land on the junction of L4 and L5. So the next spinous process you are going to press will be L4, the lower one will be L5, and you can count upward and downward like that. Otherwise, you can use the dimple at the back. The two dimple at the back are the posterior superior iliac spine, and they are X2. So if you come to the center of those dimple and you push, you are pushing on the spinous process of X2. So you'll be pushing on the spinous process of X2. And you can count X1, L5, L4, L3, L2, L1. So those different dimensions will enable you to be good with the landmark. The landmark is still what I'm trying to emphasize here. I hope we are good. The landmark is still what I'm trying to emphasize here. Hand on the iliac crest, and you trace it to the back, will land you at the junction of L4 and L5. So if you push above, you see the spinous process of L4, then you come down, you see L5. So you can go up and up like that. Surface anatomy is very important before we do the mobilization. So let's talk about those general technique. One of the general technique that we can use for the lumbar spine, you know, general technique means more than two joints will be involved in the procedure. One of the general technique of mobilization is what is called passive physiological intervertebral movement, PPIVM. Originally, it was meant to test mobility, to assess mobility of lumbar spine. But later, it now became a treatment procedure. All right? And you are going to see what it's all about. Patient will lie down in prone like this. The hip is flexed, the knee is flexed and anchored within the thigh of the therapist. All right? So you can see that the patient is already in flexion. All right. This PPIVM is a combination of three movements: flexion, side flexion, and rotation. So the patient is already in flexion. By the time the therapist lifts up the two thigh, the trunk will go into side flexion. And by the time the therapist drop it to come back to the starting position, rotation would have been done. So it's a very easy movement like that. But let me warn you, if you are a small ectomorphic physiotherapist, and you are dealing with a very huge endomorphic patient, please don't try this technique because it will tell on your body. All right, you can only use it for patients that are smaller than you in body size that you can manage. If the patient is bigger than you, don't use this one. You can use the segmental technique that we are going to talk about. I will also show this one in video illustration before we finish. That is PPIVM for the long. It's just a general technique for the lumbar spine. Just something you can warm up with before you go to the specific technique. The next one, okay, this is still the PPIVM. This is still talking about the PPIVM. The next general technique, I like this one, and this one is the commoner you will see in most textbook and journal. This is what they will describe as manipulation for the lumbar spine. This one is called rotational mobilization or alternate side lying. Okay, the patient will lie on their side. As you see, they will lie on the good side. All right, the therapist will have to make one or two maneuvers to make sure that
I hear you.
Make sure that all the movements will go to the segment that is being treated. You will see that in the video. And then the therapist will use, as you can see in the diagram, you use the right hand to push the pelvis toward himself and use his left hand to push the upper back through the bed until there's no more movement. That is taking off the slack. And then he will apply high velocity, low amplitude movements. Okay, a pop sound could come, repeat it 3 times, and then you see the gain that the patient will have. We are going to show this one also shortly before we finish. This is rotational mobilization. It's also a general technique. I'm going to show you before we finish. Then after that, we're going to look at some specific technique. We'll be looking at some specific technique for the lumbar spine, like pushing on L4 directly to increase flexion in posterior anterior direction, like pushing on L4 in anterior posterior direction to increase extension, just like we discussed for the cervical spine, and using transverse oscillatory pressure to increase rotation and pushing on the facet joints to enhance rotation, just like we discussed for the cervical spine. We are going to show that. This one are specific technique, not general technique. So we are going to illustrate all this one. And you know, even at the beginning of the class, I talk about modification for the lumbar spine. Do not use your thumb for the lumbar spine because the spinal processes are huge. So if you use your thumb, you will strain your tendon. No. So you have to use the pisiform of one wrist and you reinforce that hand with the other hand. That's how it is done in the lumbar spine. We are going to have illustration of this. As you can see in this diagram, this is the therapist delivering posterior anterior thrust on the lumbar spine of the patient. If you don't want to do serious, you don't want to do Mulligan, this is a very simple technique you can do. Once you have identified that your patient is having pain at L4 and L5, let them lie down, put your pisiform on L4, support it with the other hand, deliver that oscillation, 2 oscillations in 1 second for 60 seconds. Reassess the patient, you see the flexion has improved. All right? If you try to do it in the reverse direction, no, in the like anterior posterior direction now, you will regain extension. If you deliver transverse oscillatory pressure to the side of the spinal process, this one you can use the thumb. You don't have to use your pisiform for that. You will see that rotation has improved. We are going to show all this one in our presentation. Let me pause here and show this one before we now go to Mulligan's technique. Or should we just run through everything? Let's run through everything, then we now end up with the video section. The Mulligan's technique for the lumbar spine is very similar to that of the cervical. You remember the technique for the cervical, knacks, and movement with mobilization. All right, so it's still the same introduction that we have here. So I'm not going to bother you with that. Let's just go to knacks. All right, let's go to knacks for the lumbar spine. Do you remember the knacks for the cervical spine? You know the knacks for the cervical spine, what do? We use thumb, isn't it? We use thumb. We use index finger, sorry. We use this little finger below the spinal process and we covered it with thinner eminence. Is that not what we do? So the same thing here. If you are doing this knacks, and let me say this, knacks is not usually done on lumbar spine. It is Mulligan recommend knacks for cervical and thoracic spine. If you want to do it on thoracic spine, you use your pisiform. So this therapist is using the pisiform of the left hand and is supporting it with the thinner eminence of the right hand. Keep your elbow straight and deliver posterior anterior thrust in that oscillatory manner. All right? If you do that, 2 oscillations in 1 second or 1 oscillation in 1 second, reassess the patient and see the movement that you have gained. knacks is not usually recommended, but I use it for my patient too. But Mulligan himself did not recommend knacks for lumbar. He recommended it for cervical and thoracic, but you can still do it. But don't use your thumb because the spinal process is huge. Now, if you want to do knacks or snacks, sustained natural apophyseal glide, you can see the diagram here, and you see that it's very similar to snacks in the cervical. The only difference here again is that it is not the thumb that we are using. The therapist is using the space between the thenar and hypothenar eminence. That little depression between your thenar and hypothenar eminence, that is what you will place below the spinous process, and you push in the direction of the eyes of the patient. So you now ask the patient to repeat the movement that has been painful, flexion and extension, and you follow the patient while the patient is doing it. Rotation and side flexion, 10-10 movements. Repeat if there's benefit, and then you will carry it out 3 to 5 times. So you can see movement with mobilization in the lumbar spine, just like we reported in the cervical spine. The therapist will place one of his hand at the designated area. He will use the other hand to move the patient by himself, just like we described in the cervical spine. This movement is made a lot easier if there is Mulligan belt. If you can get a Mulligan belt and you tighten it between yourself and the patient, this movement will become effortless. You will treat 20 patients and you will not feel anything in your hand, because the Mulligan belt will be taking part of the tension that your hand or your muscle should be taking. So that's the whole essence of having that diagram at the bottom. All right. So mobilization with movement and snacks are the recommendation of Mulligan for the lumbar spine, but you can do knacks for the thoracic spine. But I do knacks also in the lumbar spine for my patients when their pain is so high and they don't want to be touched. But what I have said is that do not use your thumb on the lumbar spine. Don't use your thumb. Use your pisiform, all right? And when you are doing Mulligan, use the space between thenar and hypothenar eminence. So we're going to end the session by talking about serious technique for the lumbar spine. Okay, serious technique for the lumbar spine. You are going to have the notes anyway, so you can revise the notes and you can access the YouTube and you can learn the technique over and over. And let me say this, the more you practice, the more you become an expert. Manipulation and acupuncture, they are not skills that you learn and you abandon. Otherwise, you will not know it. Don't be shy about it. The next time you have your patients that have lumbar or cervical condition, plan manipulation and mobilization along with your treatment. Start it after this training. If you make mistake the first time, you will correct yourself in the next episode. The more you do it, the more you become an expert. You even be innovating your own technique. So the key to being a successful manual therapist is practice, practice, and practice again. So that is what I want to encourage. So let's look at serious technique for the lumbar spine. There are 3 major techniques Sirius advocated for lumbar spine. There is lumbar stretch manipulation, there's reverse lumbar stretch manipulation, and there's leg over manipulation. The lumbar stretch manipulation is just like the alternate side lying. See the patient, the way the patient is lying down here. Patient will lie on the good side, so the affected side is uppermost. The only difference between this one and alternate sideline is that the therapist is not staying at the front, he's staying at the back of the patient. But he's still pushing the upper part of the body of the patient towards the bed while pushing the waist in opposite direction until the thing is tight. There's end feel. And at that point, he can mobilize if he doesn't want to manipulate. And if he wants to manipulate, he can deliver high velocity, low amplitude movement at that point. I'm going to show it to you in the video. I know you want to quickly get into your bed to sleep, but we also have a duty to complete this assignment. I salute you for staying up tonight so that we can have this lecture at these odd hours. So, and you know what they used to say, that it's not the person that started a task that have done well, it's the person that follow it to a logical conclusion. So bear with me for the next 20 minutes or so, or 30 minutes, so that we can conclude everything very nicely. And the rest will be for you to revise with my YouTube channel and then to practice on your patients and to report your fantastic results to me. And if you have challenges with any of this technique, you know that you have a second on call in my person. If you are carrying out this technique and you're having 1 or 2 challenges, feel free to contact me on WhatsApp for an advice. I'm your second on call now. So we'll be able to discuss and advise ourselves. So this is lumbar stretch. patient lie down like this, the therapist will push both the shoulder and the hip in opposite direction until there's no more movement, and he will apply high velocity, low amplitude movement on the hip. Do you understand? On the hip, a pop sound could come. And if you don't want to do manipulation, just manipulate and mobilize in that direction. Just do about 10 mobilization in that direction, reassess your patient, and repeat 3 to 5 times. The other one is called reverse lumbar manipulation. If you watch the position of this patient here and the position of this patient here, you see that is the reverse. What is happening here? The waist of the patient is being pushed towards the bed. The shoulder of the patient is being pushed posteriorly. The waist is being pushed anteriorly. But what about in the reverse lumbar? The hip is being pushed posteriorly and the shoulder is being pushed anteriorly. That's the only difference. Otherwise, they are both the same thing. And do you know the reason why serious use reverse lumbar? You can carry out lumbar stretch on a patient, and unfortunately, the pain can go up instead of the pain going down. So instead of you checking out, because the pain have increased, when you use lumbar stretch, you will quickly resort to use reverse lumbar stretch to correct whatever would have gone wrong by you using lumbar stretch. That's the whole essence. But the procedure is basically the same thing as you are going to watch on the YouTube. And the last technique is cross leg over technique. Oh, that one is not here. Okay, it's like that one is not here. So let us take a little while to look at this video, the video of this different procedure under the lumbar spine. Please don't go anywhere. I guarantee you we are going to finish in 30 minutes or less. It's just that I will not be able to do the SIJ, but I can pass on the PowerPoint of the SIJ to the moderator for you to share. Go through it and watch my YouTube. You'll be able to get some useful instruction. And like I said, you can always contact me for further clarification. Please don't go away. We have not finished. I must show the video of this technique before we finish finally. Just give me a few minutes, please. Just give me a few minutes. Okay. Okay, this is the passive physiological intervertebral movements. Oh, it's not showing. This is the passive physiological intervertebral movement that I want to show here. It's not even about this. I'm just trying to explain something to a student that asks question here. I've not started the PPIVM at all. I'm trying to explain something to a patient that now is starting. The PPIVM is starting now. You can see the knee is flexed, the hip is flexed, and you encourage your patient to relax. Don't forget the PPIVM is about flexion of the spine, side flexion, and rotation. Those are the three movements. Even by placing the patient like this, there's some degree of flexion, but the therapist is going to put both knees on his own thigh so that there will even be more flexion. That's what he's going to do now. Now, before you will carry out the movement, you want to be sure that any maneuver is doing will be localized to the area of the pathology. That's what the therapist is teaching now. How do we make sure that whatever we are doing is at L4 and L5? That is very important before we do the maneuver. Okay? He's trying to work it out and show the student that we need to work it out, that whatever maneuver we are doing will be to the area of pathology. He's still coming to that. You can see both knees are already supported in the thigh of the therapist. That's the flexion movements. And by the time you lift up, you do side flexion. Okay. All right. I think this is a different video. There are two versions of them. In the other version, I actually teach the students what procedure to do. Okay. I think that's what he's trying to do now. Yes. You have to make sure that The movement will produce effect at the area of the pathology. That's what the therapist is trying to do now. Let's say the problem is at L4 and L5. You will have to do something first before that mobilization of PPIVM. That's it. He has placed one finger at the area of the lesion. So you can see the patient folding his own arm on the therapist's arm. So the therapist is doing a little distraction until movement is produced under the finger where the area where the lesion is. He can feel the movement under that finger now. So he will encourage the patient to maintain that position so that whatever we are doing at the end of the day will produce effect at the site of the lesion. Now he's going to grasp the leg now and move the body into flexion, side flexion, and rotation. This is flexion already. You see, it's a very quick movement. Flexion, side flexion, and rotation. Flexion, side flexion, and rotation. This is PPIVM. You remember what I said? If the patient is bigger than you in size, don't try this technique. Oh. Otherwise, you will need physiotherapist yourself, because it's practically like you are lifting the patient and you are twisting the body of the patient. So I'm going to show another technique. I'll stop sharing that one. I'm going to move to another technique in the lumbar spine. Let us look at the serious lumbar stretch now. Let's look at serious lumbar stretch. Here we go. You know, this is serious lumbar stretch. I'll play it again so that you'll understand. Can you see that? You can see the position of the patient. Therapists stay at the back of the patient. The shoulder is moved posteriorly. The hip is pushed anteriorly until there's no more movement. That is slack. Then therapists will deliver high velocity, low amplitude movement on the hip. Can you see that? That is manipulation. If you don't want to manipulate, you can just stay in that position and be mobilizing. Okay? This is lumbar stretch manipulation as taught by Sirius. Okay? So you can watch it again on the YouTube. All right? I'm going to stop this one and show another one again. Let us look at, okay, the one that looked like a serious lumbar stretch, that is lumbar extension mobilization. This is the most common one you see on YouTube or on social media as a manipulation technique for the lumbar spine, even for sacroiliac joints. They portray it as a technique for sacroiliac joints sometimes. This one, this lumbar extension rotation technique. All right, I'm trying to project that for you. All right, it is on your screen now. Let me take it back so that you can see the whole of it. All right, this is the beginning of it. All right. It's a general technique, but it can affect the lumbar spine and the sacroiliac joint. You see here, unlike in the serious, is the shoulder that is going posteriorly and the hip will come anteriorly. Before we go, the upper leg has to be anchored around the popliteal fossa of the lower leg, like that. So one hand of the therapist will find the area of pathology and pull the patient into a position until there's movement under that finger, so that any maneuver we are doing will have impact on the area of pathology. So the other hand of the therapist will pass through the folded arm of the patient, and the opposite arm will stay on the pelvis. That is mobilization. If you don't want to manipulate, you can just do this for about 3 or 5 minutes and reassess your patient. But if you want to manipulate, you know what to do. You delivered high velocity, low amplitude, and you hear the pop sound. So this is serious for the lumbar spine. I'm going to show you mulligan for the lumbar spine now. I'm going to look for the mulligan for the lumbar spine. So I want to go and search for Mulligan for the lumbar spine. Where is that one? Oh, let me go to my video again and look for it. Just 1 minute, guys. Please don't go anywhere. Just 1 minute. Video. And lumbar spine. Where's lumbar spine? Lumbar spine is there. Please don't go anywhere. I'll get it to. Where is Mulligan? Where's Mulligan? All these are serious. All right. If I can't get the Mulligan, I have the Mulligan, but let's look at the simple posterior anterior mobilization. Let's look at that one first before we now go to the Mulligan. All right. Very soon, a video will pop up on your screen. All right. This is teaching simple posterior anterior mobilization. Maybe you don't want to use serious, you don't want to use Mulligan, you just want to take it easy, deliver posterior anterior thrust, locate the site of the lesion, see what the therapist is doing. The hand is on the iliac crest. If trace it backward, that will land him at the junction of L4 and L5. So any spinous process above will be L4, below that region will be L5. All right. Yes. Saying that the spinous process of L5 is wider than that of the cervical. So don't push it with your thumb. Pisiform. That's what the therapist is teaching there. So you can see it's the pisiform that is on the bone, and one hand is reinforcing the other. It will deliver the oscillatory motion now. Can you see that? You can just do that. Do 2 oscillations in 1 second. Give the patient 120 dose, reassess. You remember what I said? If you deliver it on the vertebra above, you in posterior anterior direction, you will gain flexion. If you deliver in anterior posterior direction, you will gain extension. If you do transverse to the side of the spinous process, you will gain rotation. Now, the UPA is the one you deliver on the facet joint, unilateral posterior anterior mobilization. You are going to the facet joint to do that. And you see that that's the oscillatory movement on the facet joint. On the facet joint, you can use your thumb. But below the spinous process, you have to use your pisiform. 120 seconds in 1 minute, patient will come back and say thank you to you. And you know when we use facet joints, when we want to increase rotation and when we want to increase side flexion. When do we use transverse oscillatory pressure? When we want to increase rotation, when we want to increase side flexion. When do we use posterior anterior thrust on the vertebra above? When we want to increase flexion. Anterior posterior thrust on the vertebra above when we want to gain extension. Please don't forget, all these things have principle. And if you follow the right principle, you will get the right result. Let me see if I can still trace out the Mulligan that is running away from me. But I have it. I have all the video on my YouTube. but it would be nice if I can also get it at this point so that we can have a look at it. Just don't know where it's hiding. Okay. No, this is hip joint. This is not lumbar. All right. Okay. Maybe you have to go and look for it in on my video on my YouTube, guys. And together with the SIJ technique. So, my dear colleagues, this is quite an unusual class, isn't it? 8 to 11 class. I know some of you are under your duvet on your bed, but you have to wake up and stay till this time. I promise you, sincerely, after this hour, I'm going to give my slide to the coordinator. My YouTube link is somebody said I should share my YouTube link. It is written at the end of the presentation of cervical spine. All right, on the cervical spine, it is written at the end of presentation. Otherwise, just put Oluwaleke Ganiyu Shokunbi YouTube channel that I put for the cervical spine. So that will take you to my YouTube, and you can search for any video that you want, whether cervical or lumbar. Just type it; it will come up. Okay, that should not be a problem. I hope we have been able to influence your practice a little bit via this presentation, and I look forward to receiving a kind of feedback from you or questions or clarification as you continue to practice. Thank you so much. Thank you so much. Thank you so much. Okay, so that's going to be the end of the presentation. I'm seeing a lot of thank you, but I just want you to voice, just say one or two thank you before I close the YouTube so that I know that you are still with me.
Thank you, sir.
Thank you, sir.
Thank you, Dr. Ozo.
Thank you.
Dr. Ozo, I can see you. Thank you very much.
Thank you, sir.
Samuel, you are here.
Thank you,
Thank you.
sir.
That's
Thank
very
you,
nice
sir.
to note. Aisha, thank you very much.
Thank you so much.
Thank you very much. Oh, wonderful.
Thank you, sir.
Thank you very much. Thank you. Oh,
Thank you very much, sir.
Mr. Josaphat. So you are here. Thank you very much. Very nice to see you. Very nice to see you. Please don't forget to practice it as from tomorrow. Don't worry if you make mistakes. Read and practice it.
Thank you, sir. We will.
Get used to it. I'm looking forward to positive comment from each and every one of us. Well done, and thank you, and God bless. Sleep well, and good night.
You
Oh,
too.
Camille from Lagos. Well done, man. Well done, Camille.
You didn't tell me you are coming to Iloyo. I will have come there.
Thank you, sir. God bless you.
I'll call you. Maybe tomorrow if I don't get time.
Thank you very much, sir. We're grateful.